Hi everyone, welcome to the wrap-up session of KSC 2017. I am BK Koo from Seoul National University, and today we invite Dr. Mark Dweck from Edinburgh University.
Thank you.
Good afternoon, Mark.
Good afternoon. Hi.
Welcome to Seoul.
Thank
and
you.
On behalf of our society, I really thank you for coming and giving a wonderful lecture this morning.
Great work. It's my great pleasure to be here. Thank you very much for the invitation.
I know that you had a very interesting talk this morning related to the plaque vulnerability and patient risk, and I would like to discuss a little bit more on that topic from now on.
Okay.
So that we are very familiar to the concept of vulnerability, but for the general audience, can you briefly explain the concept of vulnerability and its clinical relevance?
Of course, yeah. So the idea of the vulnerable plaque really relates to how we can identify the plaques that are at increased risk of rupturing and causing myocardial infarction. So we know from pathological studies that these plaques have certain histological characteristics. So these include things like a thin fibrous cap, inflammation, microcalcification. And the idea really is that if we can identify these higher risk plaques using imaging techniques, that we might be able to better predict the plaques that are going to rupture and the patients that are more likely to have myocardial infarction.
Okay, so that it's good to have that kind of concept into our daily practice, so that the concept is there, but the issue is that how can we define and how can we handle with the vulnerable plaques, so that can you explain in detail how can we detect the vulnerable plaque with the current available invasive and non-invasive technologies?
Sure. So really the technology started with invasive techniques, and with these techniques introducing catheters into the body, we can pick up certain characteristics. And this culminated in the Prospect trial. So in that trial they used VH-IVUS. We can argue about whether that's the best technique to use, but nevertheless they were able to identify VH-IVUS defined TICFAs, and they followed these patients up. And they identified about 600 of these plaques using invasive techniques. And what was interesting in the trial, I think the biggest message from the trial is that in the entire study, after 3 years, there was only 6 myocardial infarctions. So we have 600 plaques and we have 6 myocardial infarctions. And that's not very many. And I think what that has taught us is that at the individual plaque level, these plaques don't always go on to cause events. In fact, the majority will heal without anything happening. So I think if we look at the invasive techniques where we're talking about finding plaques that maybe we're going to treat with stents, I'm not sure this strategy makes an awful lot of sense, because the predictive value just isn't there. However, on the non-invasive side, we can also start to detect these plaques, and we can use CT, we can use MRI, we can use PET imaging to identify higher risk plaque characteristics. And it kind of works because what we realize is that patients don't have just one of these lesions. They develop lots of these lesions over time. And so if you're a patient that has a propensity to develop these higher risk lesions, several studies now have shown you are more likely to have an event than patients who develop more stable type lesions. So at the patient level, I think it works. And then, of course, we're not talking about individual plaque-directed therapies, we're talking about systemic drug treatments to try and avoid events from happening. So there's been a lot of debate about whether the vulnerable plaque strategy still is worth pursuing, and I think at the patient level it still makes sense.
I see. So I think it's a good point. So that, as you pointed out earlier, actually Prospect study was really a wonderful study, but the issue is that it's low positive predictive rate.
Exactly, yeah.
So is there any way that we can improve the positive predictive rate with any other available device or new devices we have?
Yeah, so I mean we're doing a lot of work with PET-CT, and the great advantage really of PET-CT imaging is that you get the information from the CT, you get measures of plaque burden, you get measures of whether lesions are obstructive, and also the high-risk plaque characteristics. And then on top of that, you get an assessment of disease activity. So you can start to differentiate patients that have stable burnt-out disease versus active atheroma. And our hypothesis is that if you put all that information together, then we might really get some accurate risk prediction methodology. Now, of course, we need to establish that in the context of a prospective multi-center observational trial, and that is ongoing with the PREFER trial. So I can't tell you for sure now. We need to wait. I guess 5 years' time we'll know the answer of PREFER and whether it adds anything over and above existing tools that are perhaps cheaper and easier.
I know that you are an expert and you did wonderful studies and published on the sodium fluoride PET scan. So I think that to many of the audience, it's kind of a new or novel technology. So that can you introduce the concept and why the sodium fluoride PET is working and what was the result you have as of now?
Yeah, so we've long been interested in trying to do PET imaging in the coronary arteries, and we've used FDG imaging for that purpose for a while, and it hasn't really worked. We've used a different tracer. So fluoride is a tracer that detects microcalcification. That is the very early stages of calcification. And that's an interesting target because what we know is that the early stages of calcification are associated with increased plaque vulnerability. In contrast to the later macroscopic calcium we see on CT, which is associated with stable plaque, early microcalcification is consistently associated with ruptured plaques, culprit plaques, vulnerable plaques. And so this tracer is good on several accounts. Firstly, you get excellent signal in the coronary arteries, much better than with other tracers to date. And secondly, we've got an interesting target with microcalcification. So in a study recently, we looked at patients who'd had just had a myocardial infarction. And what we showed was that in over 90% of these patients, the culprit plaque, the plaque that had ruptured and caused the myocardial infarction, was lighting up with our imaging technique. So we know that after the heart attack, we can pick out the plaque that ruptured and caused the event. So that's pretty good, but what we really need is to be able to do that before the event, so that we can do something to stop the event from happening, and that's why we need these prospective studies to see if we can do that.
So that it's a very interesting concept because that the calcifying activity is kind of another element of the vulnerability, but some may argue that the calcification also represents the stability of the plaque.
Sure.
So can you briefly comment on established calcium and the calcifying activity in terms of vulnerability issue?
Yeah, well, I think, calcification in atherosclerosis is, to me, a very interesting topic. And I think the body has a couple of mechanisms to heal. One of them is calcification, and often that calcification occurs in response to very intense inflammatory activity. So if we think about tuberculosis, for instance, you have intense necrotic inflammation, you have calcification to try and heal that up. And increasingly we're thinking that the same process is occurring in the coronary arteries in atherosclerosis, where intense inflammation in the necrotic core leads to a calcifying response that tries to heal up the plaque. So I think it's useful to think of calcification as a two-step process. Once we get to the end, macroscopic, big lumps of calcium, the calcium has kind of done its job. It's healed up the plaque, the inflammation is gone, we have a nice stable plaque. And this is what we see when we do CT imaging, when you see calcification on invasive coronary angiography. It's that end stage process we're seeing there. But before that, before we get to the macro calcification, we have to go through this micro calcification stage. And by contrast, this stage is associated with increased plaque vulnerability. Now, in part, that's because there's still inflammation in the plaque that needs to be healed. It hasn't quite done its process yet. But also, the microcalcification might itself increase the risk of plaque rupture by weakening the fibrous cap, potentially making it more vulnerable to rupture. So for two reasons really. This microcalcification stage is a higher risk stage. We haven't quite yet got to the healed up macroscopic calcium that we know imparts stability.
Okay, so that I think it's really a very interesting concept, and I'm very excited to hear that there's a scientific background for using the sodium fluoride PET or the early calcifying activity into our clinical practice. And you already published several data, but as far as I know, it's still in the research volume, whether not in the clinical, in the practice. So that when do you think it will be incorporated into our clinical practice, and how much data or what will be needed for that process?
Sure, I think we are in truth a little way away from that. This is right at the beginning of the story of fluoride PET, indeed coronary PET in general. And the first thing we need is a prospective study to show that when we image patients with PET-CT, that the people with increased activity are the ones that go on to have events. I think we need to establish that. And then I think if we're ever going to use this, we need to show that it is better than cheaper techniques, measurements of plaque burden, say on CT, or cardiovascular risk scores. And if it offers improved prediction, then perhaps it will enter routine clinical practice. But we have to remember this is quite an expensive imaging technique. And so I think its use is going to be people at the real high end of the spectrum. People who we know have advanced disease, where we're really trying to refine risk prediction. And in these patients, then we might be able to differentiate people with active disease versus stable, burnt out disease, and perhaps target the active patients with expensive new medications, PCSK9 inhibitors, bypass surgery potentially. Whereas with the people with stable, inactive disease, perhaps we can be less aggressive. Maybe they don't need the bypass surgery. Maybe we don't need to spend all that money on PCSK9 inhibitors, anti-inflammatory agents. So I think that's where it might find its clinical role, but we need the prospective studies to confirm that it's actually useful clinically.
So that my last question is about how can we deal with the vulnerable plaque? You in part answered that question with previous comments, so that can you briefly express your thought on the current treatment strategy for vulnerable plaque?
Yeah, I mean, I think this applies to PET, but also to CT and MRI. I think once we have slightly stronger data that identifying these plaques identifies a subgroup who have worse events, then I think treatment is medical therapy, because we know that the positive predictive value of an individual lesion is low. So stenting that lesion, I can't see having a benefit. But if we treat the patient systemically with medical therapy, then I think it starts to make some sense, because we're treating not one plaque, but all the plaques. And so I think with more data, if we know that vulnerable plaque identification is useful, then I think it might be a way of targeting aggressive, expensive medical therapy to certain patients. But also, I think equally important is withholding therapy. So an interesting area is, say, people with multi-vessel disease. If you identify patients who have stable burnt out disease, perhaps they don't need an operation, perhaps they don't need expensive therapy, and so we can ration the expensive and invasive treatments that we have.
Okay, so thanks Mark for the very active participation of this wrap-up session. So I really enjoyed your talk and your discussion. And I also hope that all the audience really enjoyed this new concept. And hopefully, I hope that this concept will be in our daily practice in near future with our collaboration. Thank you very much.
Thank you.
Thank you.
Great.